So how do you tell the difference between DKA and HHNS? Well, DKA is more common in type 1 diabetes and HHNS for type 2. So think which letter comes first in the alphabet? Well guys, D comes first, so it's type 1, and H comes second, so that's how you know it's type 2. Now, what is DKA? Well guys, let the name help you. Diabetic ketoacidosis. There is no insulin produced since it's type 1, guys. We have none. The body killed its own pancreas, and as usual, no insulin means no sugar in the cell. Therefore, the body must burn fat for fuel, resulting in fat waste, and ketone bodies are produced. Kind of like how a diesel engine blows off a lot of exhaust, ketone bodies are very acidic wastes. So we have high acid in DKA, or diabetic ketoacidosis. Now type 2, we have few insulins barely working. So HHNS or just HHS, let the name help you. So hyperglycemic, we have the higher sugar. Hyperosmolar, we have very thick dehydrated blood. Guys, huge dehydration here. And non-ketonic, we have no ketones, and S is for syndrome. Now, since the body has barely enough insulin to put sugar into the cell, well, the body burns sugar for fuel, so we don't get those ketone bodies. So guys, think type 2, you have a few insulins working, so no fat burn, no ketones, since the body's burning glucose. Now, typically, DKA has a faster onset, and consequently, it's easier to fix, since the patients are young with type 1 diabetes. And HHNS is a slower onset with older patients. So guys, it's harder to fix HHNS. Now for the causes, DKA, remember the 3 S's like high sugar. So sepsis, like infection, guys, always an NCLEX favorite. The #1 cause of DKA is infection. Second S is for stress like surgeries or even skipping insulin. Guys, kids in type 1 will get the flu or an infection and then boom, end up in DKA. Or they'll go to surgery without increasing their insulin dose and then bam, DKA. And similarly, on the other side, older patients in HHNS commonly caused by illness and infections. So what are the main differences in the signs and symptoms? Well, for DKA, this is super hard, right? Just remember the acronym DKA. So D for a dried body, guys, and high sugar. 250 to 500 from the lack of insulin. Guys, that's a huge key word. 250 to 500 with type 1 diabetics. Now, K is for ketones and Kussmaul respirations, or known as fruity breath. Key words here for the NCLEX. Deep, rapid breathing that smells fruity. This is called Kussmaul respirations. So think ketone respirations. So we say, ketones, do you love me? Are you riding? The body is in metabolic acidosis. So the body tries to correct itself, or basically compensate, and get rid of all this acid. It does it by panting like a dog to breathe out all that carbon dioxide, which we call carbon diacid. So remember, we'll see Kussmaul respirations as deep, rapid breathing as the body tries to get rid of all this acid. And the memory trick here is carbon diacid. Now next, our A is for abdominal pain, which is a huge NCLEX tip. HHNS does not have abdominal pain, only DKA, typically on the NCLEX. And our last A is for acidosis, metabolic acidosis, guys. Huge NCLEX key number here. Write this down. pH 7.35 or less. Huge number on the NCLEX. It will always show up on static questions. Now switching over to type 2, the slower and more serious one, since it's harder to fix. So HHNS, guys, remember the triple H's here. We have higher sugar loss with higher fluid loss. So sugar over 600 plus and extreme dehydration. And our third H is for head change. Now the NCLEX term is neurological manifestations, guys. Write that down. We'll often see confusion with classic signs of HHNS. Guys, we don't get head change or neurological manifestations with DKA. Our next N is for no abdominal pain, guys. DKA, we have that abdominal pain, as well as no ketone ketone. So this means no acid, no Kussmaul respirations, basically meaning no fruity breath and no deep, rapid breathing. Now that's probably the biggest difference than DKA. And lastly, S is for our slower onset with stable potassium, 3.5 to 5.0. So when you get an NCLEX question stating high sugars with neurological changes or neurostatus changes, guys, with no acid, definitely HHNS. And if you get a question about a diabetic kid with abdominal pain and that pH less than 7.35, guys, it's most definitely DKA. So guys, what are we gonna do about it? So for DKA treatments, simply remember the acronym DKA. D for dehydration. Guys, we treat the dry first. Keyword is 0.9% normal saline. Now, I got a lot of questions on this from our NCLEX review, so please write this down. Your first priority action for both DKA and HHS is fluids. The correct answer is always normal saline. Now, K is to kill the sugar slowly, guys, to prevent that low sugar. So we do keyword here, hourly blood sugar checks. Write that down. We want a slow sugar drop. Sugar is really way high, kind of like a plane. So guys, we want to land that plane slowly, not too fast, since we don't want to crash our patients here. The main goal here is to prevent that low blood sugar, that hypoglycemia, that 70 or less. So a slow sugar landing is the goal. So basically, as sugar lowers, then the insulin lowers. We just titrate or adjust the insulin drip and lower them together. Typically, any sugar over 250, we give IV insulin. Now, key term here, regular insulin only. So remember, regular insulin is ready to go IV. And we start with the bolus first, basically meaning rapid infusion. Now, caution, tests will try and trick you guys. Only regular insulin is put right in the vein. Not NPH, not Aspart, not Lispro. No one else here gets the VIP pass. Remember, only regular insulin is right in the vein or ready to go IV. Now, when sugars drop below 200 or when, keyword, write this down, ketones resolve. This means the body is now burning glucose for fuel and not fat anymore. So we switch the patient from IV insulin to sub-Q and then add some dextrose sugar to the IV bag, typically D5W. Now you're probably asking, why do we add sugar if the sugar's already high? Well guys, it's kind of like landing that plane. Sugar is our landing gear. We want a smooth and slow landing, preventing that low sugar crash of hypoglycemia. Now, a common test question is always a question about a child in DKA who's too nauseous to eat or maybe vomiting. And the question always says, do you still give him insulin if he doesn't have food? So think about it here, guys. Well, yeah, you still give the kid insulin, guys. His sugar's really, really high. Big NCLEX tip. Still give insulin on those sick days. Lastly, we add the potassium. Key word here, write this down. During IV insulin, not after. During. Big NCLEX tip. And yes, even when potassium is normal between 3.5 and 5.0. Now you're probably asking yourself why. Well guys, remember, insulin puts sugar and potassium into the cell. So naturally both sugar and potassium drop together. So to prevent a potassium crash, we add potassium, sort of like how we add sugar. Now, a little side note about potassium. Think potassium pumps the heart. So the 4 rules of potassium revolve around protecting the heart with potassium. Number 1, our first action is heart monitor placement. And secondly, guys, we never push potassium. This means sudden death. The heart will cramp up and not pump anymore. Third, we only do 10 to 20 mLs max per hour. Not 30 minutes, not even 45 minutes, guys. Per hour, a full 60 minutes or more. Usually around 4 hours. And lastly, we always put potassium on an IV pump. Never a solo drip, guys. It's too risky. And as always, slow the infusion pump if the arm starts burning, which is pretty common. Now, to help you remember the ECG rhythms with high versus low potassium, our memory trick is very simple here. So just think high potassium, we have high pumps. So we get peak T waves and ST elevations for potassium over 5.0. And the exact opposite for low potassium, below 3.5, just think low pumps. So we get flat T waves and ST depression, and even this weird little U wave. What the heck's a U wave? Shut up, you. Now for HHS treatments, guys, remember the acronym HS. We always treat the hydration first. Both DKA and HHS, hydration first. 0.9% normal saline. Huge NCLEX tip, guys. Now, we can always do hypotonic fluids, but that's not as common on the NCLEX. And then S for stabilize the sugar with insulin. Again, caution, guys, only regular insulin is ready to go IV. Big NCLEX tip right there again. And just like DKA, we correct the sugars slowly with key term hourly blood sugar checks and insulin going from IV bolus to subcutaneous injections. We land that sugar slow. Now, as far as potassium for HHS, out of 10,000 questions we took while making the script, the potassium only came with DKA. So guys, remember, adding potassium for DKA. But a lot of questions came up about reassessing the hydration status. So write this down, guys. So we reassess both blood sugar and rehydration status. So for hydration, we'll see stable blood pressure, cap refill 3 seconds or less. And guys, skin, write this down, should not be pale or cold. It should be warm and have some color. Urine output should be 30 mLs per hour or more with normal specific gravity. Too high and the body is dry. So the little memory trick here is hemoconcentration is an indication of dehydration. Basically meaning high and dry lab values, very heavy urine. And hemodilution is overhydration, low liquidy labs with low liquidy urine. Lastly, don't let the NCLEX trick you. Rehydration status does not include apical pulse, lung sounds, or even pupil assessment. All right, guys, that wraps it up. DKA